About 60% of newborns develop jaundice during the first week of life. This is usually harmless. However, infants with severe jaundice may develop bilirubin toxicity, which, if not treated quickly, may lead to permanent brain damage, commonly called kernicterus. In this presentation, you will learn about kernicterus, how it affects newborns and survivors, why it is so common in Africa, the Middle East, and Southeast Asia, and what can be done to prevent it. The name kernicterus was first assigned by a pathologist to describe icteric or yellow staining of specific regions of the brain found in newborns who died with severe jaundice. The affected regions control coordination, hearing, and specific muscle groups, but notably areas of brain involved in cognitive functions are spared. Why do newborns develop jaundice? Jaundice is created by elevated plasma bilirubin, a yellow pigment produced from hemoglobin when red cells are destroyed. Red blood cells are normally replaced about every 100 days. Bilirubin is eliminated by the liver into the intestine, but liver enzymes needed to excrete bilirubin have decreased activity during the first week or more of life, resulting in neonatal jaundice. This graph illustrates the rise of plasma bilirubin in a population of healthy term or near-term infants during the first week of life. Plasma bilirubin levels usually peak on the 5th day of life. At that time, 95% of healthy term newborns will have a bilirubin level below 18 milligrams per deciliter. The risk for bilirubin neurotoxicity in healthy term infants is low if the bilirubin level is maintained below 25. If excessive bilirubin is produced while the liver has limited ability to eliminate it, then the serum bilirubin concentration can reach dangerous levels. The most common reason for high bilirubin production is increased red blood cell destruction, which we call hemolysis. Here are the most common causes of severe hemolysis in newborns. Jaundice from Rh or ABO incompatibility may occur when a mother with type O or Rh negative blood has an unborn baby with a different blood type or is Rh positive. If the baby's red cells leak into her circulation, she may develop antibodies to them that cross the placenta and attack the baby's red cells. G6PD enzyme deficiency is an inherited condition that increases the vulnerability of red blood cells to several drugs and chemicals. It is the most common cause of severe jaundice in sub-Saharan Africa and is also prevalent in many regions of the Middle East and Southern Asia. Severe bruising and certain infections may also increase red cell destruction. If the bilirubin level becomes high enough to affect brain function, infants become sleepy, often irritable, and stop nursing well. These are signs of mild acute bilirubin encephalopathy, or ABE. They will resolve with intensive phototherapy, and long-term consequences are rare. But if not treated quickly, mild ABE may progress to severe acute bilirubin encephalopathy. This infant has severe ABE. His head and back are arched, his extremities are stiff and extended. His cry is shrill and he is unresponsive to feeding or comforting. He will likely have permanent brain damage from kernicterus if he survives. Babies with acute kernicterus often have an anxious, blank stare, rigid facial expressions, poor eye coordination, and uncoordinated sucking, as does this 6-day-old baby in Nigeria. Older patients with kernicterus have a spectrum of clinical manifestations. Some only have hearing loss, but most patients have varying degrees of abnormal muscle tone and uncoordinated movements. Dystonia also leads to difficulty in speaking and eating. In addition to nervous system targets, bilirubin can stain and impair the development of deciduous teeth. But it is important to remember that most patients with severe kernicterus have normal intelligence, although they may be locked into a painful body that does not work. This is Rasha, a 4-year-old Egyptian girl with a becoming smile. She has severe dental dysplasia typical of kernicterus, and she has very poor truncal tone and head control, but increasing tone in her extremities, with uncoordinated movements of hands and feet called athetosis. She has severe hearing loss and difficulty coordinating muscles needed for eating and speaking. The tragedy of Rasha is compounded by the fact that it did not have to happen. Kernicterus can nearly always be prevented with appropriate treatment, even in most cases of severe hemolysis. Phototherapy is the treatment of choice and can rapidly reduce the plasma bilirubin level in most babies. Blue light, as seen here, is more effective than white light. Bright light changes the structure of bilirubin and allows it to be excreted into the intestine without the need for enzymatic transformation by the liver. Why is kernicterus so common in low-resource settings? There are many reasons, but 4 factors stand out. First, in sub-Saharan Africa and many low-resource countries, G6PD deficiency is common, often resulting in severe jaundice if not treated quickly. Secondly, a low awareness of the dangers of jaundice among parents and health workers often results in delays in seeking care. Babies with severe ABE and kernicterus are most often brought to the hospital because they are sick, not because they have jaundice. Third, the failure or inability to measure plasma bilirubin concentration impairs doctors' abilities to identify newborns in need of treatment. And finally, many treatment facilities lack high-quality phototherapy to treat jaundice. 4 critical interventions respond to these issues. If we are to stop kernicterus, we must educate parents, birth attendants, and health providers about risks of jaundice to facilitate early evaluation and treatment. We must identify newborns with G6PD deficiency as soon as possible after birth and monitor them closely. We must be able to estimate plasma bilirubin at community clinics. And we must have a referral system to centers that can treat severe jaundice with effective phototherapy. Students at Seattle University have made many contributions to help transform these goals into action, providing tools to prevent kernicterus worldwide. They created a Stop Kernicterus International website that provides a library of training materials for parents and health workers, offered in multiple languages. They created a cell phone app to measure plasma bilirubin using a single drop of blood, and recently expanded the app to give parents easy access to information about jaundice and its risks. And they developed a telemetric system to monitor the regional incidence of severe jaundice and kernicterus. Students now have an opportunity to create an important smartphone-based assay for G6PD activity. Knowing whether a newborn has G6PD deficiency is important, since hemolysis and severe jaundice can be induced when affected infants are exposed to certain drugs and substances. Commonly used substances that can be absorbed through the skin and trigger hemolysis include henna, naphthalene, and mothballs. Parents of G6PD deficient infants must wash clothes stored in mothballs before using. Kernicterus is easy to prevent, but impossible to cure. Prevention is not complicated. The cost of education, evaluation, and treatment is low compared to the cost of lost lives and caring for patients with damaged brains.